All right, well, we'll go ahead and get started. Thank you all for joining us here in the question and answer session for Cherished Futures for Black Moms and Babies, centering Black voices to drive system change. I am Shaquelle Ballou. I'm a program analyst on the Women's and Infant Health team here at AMCHP, and happy to be moderating this session today. I'm joined by two of our presenters. Thank you all for tuning in for the session. If you did not have the chance to post your questions in the Cadmium platform, feel free to come off mute here in just a second or add them in chat and I'll let our presenters address them here. But before we get started with questions, I will pass it over to our presenters to introduce themselves. Esther, you're closest to me on the Zoom screen, so I'll get started with you.
Yeah, I just was thinking about how much coordination goes into planning a virtual conference. And honestly, thank you both, Shaquelle and also Courtney and all of your colleagues for all the things that have to happen behind the scenes to make this happen. Because there's multiple Zoom, Cadmium, there's all these platforms. Y'all serve as a birth equity impact analyst with Cherished Futures for Black Moms and Babies here in Los Angeles, which is where I currently am. And I am I recently graduated from Georgetown University last summer. And I actually came to know Cherished Futures, yes, yay, woo woo, from grad school. But I came to know Cherished Futures as a birth equity fellow. So I started my work last summer and more than happy to be in a position where I can continue doing this work on the team. And I will be continuing my studies this fall as a PhD student at UCLA. So I'll just throw that out there. If anyone has advice for me, feel free to put it in the chat or whatever. But I will now hand it over to my colleague, Asaya. Take it away.
Thanks so much, Esther. And yes, kudos to all of that schooling, because Lord knows it's not easy to be working and doing school and all of that. So we love that Esther is able to continue with us in Cherished Futures. Hi, everyone. My name is Asaya Harville. I am the Birth Equity Coordinator with Cherished Futures for Black Moms and Babies, also in Los Angeles, California. Really excited to be here with you all today. We really take pride in this initiative and really hopefully this movement to address the disparities that Black moms and babies are facing. So I come to this work both personally and professionally with a lot of experience there. And separately, I'm also an international board certified lactation consultant. So as we know, there is a nationwide formula shortage, which has brought up all kinds of equity issues and impacts on families who are always often, the most disproportionately impacted. And so definitely working with some folks around that issue as well. And I'm just really happy to be here and looking forward to answering the questions that you all might have.
Thank you both for those introductions. Esther, so excited to hear about all of your schooling and just very cool. I'm here in the DC area, so hearing you went to Georgetown is pretty cool. But I will take this moment here to open it up to all of our attendees here. If you did not have a chance to post your questions in Cadmium, feel free to come off of mute or post them in the chat. And I guess to get us started, it was really cool just to hear about how many different folks are involved in the collaborative. And I can imagine how, challenging, it could be with so many people at the table. So just wondering what challenges, if any, do you all face with considering this multi-sector collaborative with hospitals and community, and just how you all move forward with those challenges?
Esther, you want to start with that one? Or you want me to start?
Sure. Sure. And I'll say that there's a little bit of lag with my internet connection. So if I interrupt someone, please let me know. But there's a lag with the audio and video. But yeah, so Cherished Futures, and I thank you all, those who have watched the recording, thanks for watching and being and attending. We mentioned this a little bit in our presentation, but the Cherished Futures Collaborative, it's multi-sector, which just refers to the fact that we are working with and guiding folks from different industries. So it's very much interdisciplinary. So we have our hospital cohort teams, which are comprised of clinicians and hospital staff, which includes QI folks, OBs, nurses, nursing executives and leaders, et cetera. We also have our community advisors who are public health professionals and experts in their field who have been doing this work collectively for decades, and just very proud of the work that they continue to do, a lot of grassroots work here in LA County. And then we also have our public health partners and payers, which include some funders, some health insurance organizations, and public health departments and jurisdictions across LA County. And that's not to mention some of the other folks that we've partnered with, other ways that we're expanding the work of Cherished Futures. But with all of that, all of those different sectors and industries and disciplines, there are challenges just with scheduling, challenges with finding time that aligns for folks. These are very busy people that we work with. And then there are sometimes challenges that come up around how the work gets done. So ideological challenges, and what we tend to return back to in Cherished Futures, whether we're presenting at our own convenings with our hospital teams, or whether we're meeting with our community advisors, as we were doing earlier today. We constantly get back to a space of level setting, to a space of why exactly are we doing this work to accomplish in a shorter amount of time? What do we hope to accomplish during this meeting, or what do we hope to accomplish during this quarter of the year? And by making space for that time to level set, making space for certain foundational questions to be answered, we're able to better do this work. And it's not the easiest, and I'm sure Asaya can speak to other challenges or other lessons we've learned over the past few years. But I think the level setting piece is especially important, knowing that there are folks who are newer to this work. Some of the folks in our hospital teams are nurses and have been nurses for decades, but are not familiar with the concepts of birth equity, perinatal equity, reproductive equity. Some have just become comfortable saying the term Black woman, which will always blow my mind as a Black woman. It'll always that's very interesting to me. But some folks really, truly have not been comfortable saying those words out loud. These are folks that we work with. And so it's interesting to see the trajectory of their own journey, and to make sure that we're always returning back to, this is a space for learning. Let us answer questions with respect, and all with this common goal in mind. So I'll pass it over to Asaya to add what she wants to that as well.
Yeah, that's great, Esther. The only thing that I would add would be, because there are so many kind of separate entities involved, whether it's hospitals, healthcare systems, public health, insurance payers, ourselves within Cherished Futures, our partners at the Hospital Association, it sometimes can be difficult for us, even internally, right, to have kind of the same ideas or strategies around how we want to approach this, right? So, someone from a public health, looking at things from a public health lens might want to approach things in one particular way, and that doesn't translate to clinicians very well, or vice versa. And then from an insurance standpoint, it's how to get them involved with understanding that this actually impacts their bottom line, right? And unfortunately, they look at things from more of a financial perspective. So it's really, the challenge is trying to meet everyone's kind of whatever their bottom line is, whether that bottom line is about patient satisfaction or patient experience, patient outcomes, or, making sure that they are not, constantly overpaying in reimbursement for facilities and institutions who are, performing less than stellar for their Black patient population. So I would say that overall, it's just a challenge getting everybody on the same page. And like Esther mentioned, we do a lot of level setting, a lot of foundational, knowledge building, and even just language, understanding of language. There is a common theme that comes up in a lot of our work, that's I treat everybody the same. And what we have to try to get folks to realize is that is part of the problem, because everybody doesn't come in with the same things, right? So I think it's just, the overall getting everybody on the same page and making sure that they're on the same page, so that when we move forward in the work and we start addressing those interventions and how do we measure progress, they're all starting from a place of the same understanding.
That's great. Thank you both. And we have another question that came through chat. Thank you, Candace. How did you initiate the relationship with the hospitals and having them to the table?
Yeah, that's a great question. So the way we kind of approach the hospital teams is by showing them their own data. So here in California, we have an organization called CMQCC, which holds, they are, the hospitals are their members. So they are the ones who actually hold all of the hospital's data for their outcomes, maternal outcomes, in great detail. And they have something called the Maternal Data Center. And within the Maternal Data Center, you can actually look at your own hospital's numbers, disaggregated by race and ethnicity. So that's where we start, right? We bring the hospitals their own data, and the way we did it for this cohort 2, is that we basically looked at who were the hospitals that were delivering the largest proportion of Black births for this area, and then we pulled out their numbers disaggregated. So looking at various measures, whether it's primary C-section rates or failed inductions or hemorrhages or whatever maternal morbidity or comorbidities existed, and then showing them their own data coupled with, how we within Cherished Futures can help support them to change and really start to address those disparities that lie within their own data. And then we present it to them, and it's a choice. They don't have to sign on and say, yes, we want to participate in Cherished Futures. They can very, very much choose not to. They can say, well, we've done equity work elsewhere, or, whatever the case may be. But that's how we initiate those conversations, is presenting them with their own data. We meet with the hospital leadership. So it's usually CEO, CNO, anybody from C-suite, QI, if there's QI available, because, this really is a quality improvement initiative. And so if we're looking at it from that perspective, it's just like any other QI work in the hospital. And then again, the hospital can choose to sign on or not based on what their perceived or actual capacity is for doing this work. And we go from there. And this cohort, we are really pleased to be able to have the 5 sites, really it's 6 sites, with UCLA being a 2-site hospital. And we're excited to see where they go from here.
And Nicole, I think we're on the same wave, because I had a similar thought here. Did you experience any reluctance from healthcare providers or hospital leadership?
I can share a bit about this. This is always a great question, because we know that not every hospital is at the same level, not just when it comes to commitment to this issue, commitment to advancing birth equity, but also like straight up capacity. It's just very glaring when you work with a number of hospitals. You're able to compare and contrast between how meetings go, the types of questions that come up, the response rate, whether folks are really engaged. And so, between cohorts 1 and 2, our collective Cherished Futures cohort of hospitals definitely range. They're definitely across the spectrum when it comes to sustained commitment to this work, when it comes to hospital executive leadership supporting this work, and then of course, when it comes to capacity. Some hospitals have high turnover. Some hospitals are really stretched thin. And for cohort 1 hospitals, that was, our cohort 1 was launched right at the top of 2020, right at the beginning of the pandemic, and the burden that caused on the cohort 1 hospitals was pretty unmistakable. There was a lot going on in our healthcare system, especially in California. It's a whole other conversation. And so, yeah, there have been quite a lot of barriers there. Sometimes the reluctance comes from what I mentioned, capacity, and just that being limited, staffing, turnover, and funding issues. But sometimes the reluctance comes from folks just not understanding or wanting to understand this issue, and not wanting to do the personal work themselves, which there's only so much that we can do. As a Cherished Futures team, we really count on our collaborative partners being, one of my friends uses the word earnest a lot, that earnest intention, or that earnest interest in this work that is not performative, but is truly intentional. It's like, I really do want to be a better provider or a better community member. And I think that's something we should all strive for. So we work with folks really across the spectrum, and I'm going to revisit the question because I hope I'm answering the question. But yes, we do experience reluctance, and we've our muscles have strengthened when it comes to dealing with and kind of navigating that across all of our different hospital teams.
And I'll just really quickly add to that, there is two types of reluctance in many ways, right? There's that personal kind of, well, I'm doing this particular thing in my role, and so I do not feel I need to do extra. But then there's also the institutional responsibility and accountability, or lack thereof, depending on what is actually happening. So I think that we have to also address both of those things, that the reluctance can sometimes actually be from the institution. And so, sorry, my little one has decided to join. But yeah, so the reluctance can both be on an individual basis, but also an institutional basis. And so navigating those kind of two situations can also be challenging, but you know, that's what we're here for.
And absolutely no apologies necessary for your little one joining. Please bring them if they want to join. We have another question from Rosie here. How do you keep yourselves from having preconceived ideas about your research, whatever it may be?
I saw that question. I would love, Rosie, if you don't mind coming off of mute to ask the question or to explain the question, just so I'm not misunderstanding it.
Okay, can you hear me okay?
Yep.
Okay. I have been involved with situations in which I have to deal with people that are a lot like myself as well. And I'm a Black female. And I have found myself at times when I do that I can't keep myself from out of the validity of what I'm trying to accomplish, because if I become emotionally involved, or else I'll go in with the idea that if it feels this way to me, it has to be that way for that person. And, you know, emotions get involved and just preconceived ideas as a Black woman. Does that make sense?
It does.
Absolutely. Esther, do you want to start? No, go ahead. I'm going to say you start, and then yes. I will definitely, I'd love to answer those.
Yes, it does. Thank you for raising that, Rosie. It definitely sounds like you're also getting at, this work is deeply personal. So like, how do y'all do that? Like, how do you manage that? This is on my mind all the time. And we do talk about this as a team. I'm very grateful to be on a team of other Black women doing work that supports Black women and birthing people. It's like, you know, up there with, I just feel very honored to be able to do this work. But I definitely understand what you're saying when we are reading research articles or referencing certain data, especially data that's, you know, disheartening. It is kind of difficult. And sometimes I want to be very intentional about how I share information, or when we're to either the community advisors or members of our hospital cohort teams. I think at the end of the day, you know, many of us who work in healthcare, those of us who work in public health, or who are clinicians providing direct patient services, you know, between Asaya and I, we've both worked in clinical spaces providing clinical care. We also work as public health professionals, and we've kind of seen many different sides of this work. At the end of the day, we just want to see our people be well. We want to know that we ourselves can move about this world, move about clinical spaces with safety in mind. And yes, that can be an emotional topic, or, you know, day to day, that can be kind of heavy. But ultimately, that's just the goal. Like, to me, it should be everyone's goal. So for me, sometimes it's very matter of fact, and it's very, you know, if this is what the data says, this is what the data says. And so it requires a level of blanking on the word, but, you know, just matter of fact. Like, this is a matter of fact. And something I'll also raise, I was in another meeting about health policy and earlier today, and someone was asking me about evidence-based trainings or evidence-based initiatives versus community-informed initiatives. And she posed this question to me like they are opposite, like they are, that they are mutually exclusive. And I, you know, respectfully was just, you know, I mentioned to her, this work kind of requires a paradigm shift or a shift in your own thinking, because what is defined by the community is evidence. And that's not something that academic institutions and clinical institutions have respected. So much of the work that we do, yes, sometimes it can be a bit emotionally charged, but it's also powerful work because we're creating new knowledge that was not there before. It's a lot of growing Cherished Futures. We uplift what our community advisors raise up, and we uplift the needs of the community as evidence. That is and always will be evidence. We're human beings, our experiences should always be regarded as valid. So just kind of like making that a matter of fact is kind of the energy that I try to bring to a lot of these spaces. Thank you for asking that question.
Yeah, thanks. Thanks, Rosie. I think it's a valid question. And I think it's something that, within Cherished Futures, we try to be mindful of, right? Because data is one piece of it, but it's not the whole story, because data can be manipulated, right? It can be manipulated to tell whatever story you want it to tell based on who's telling it at the time. So I think for us within Cherished Futures, sorry, my little person is here. The goal is really to use both. And just as Esther was saying, it's not just about evidence-based from a clinical standpoint, right? Because yes, there are things that need to be evidence-based in research, but we also have to keep in mind that research historically and traditionally keeps out Black people, right? It separates us from what is possible, what is doable, et cetera. And so we have to bring in our own lived experiences, because we are typically not a part of research. We are typically not a part of studies. Unless it is to capitalize on our experience oftentimes, right? And so, we want to hear from Black moms. We want to hear from Black moms, but then we don't want to actually input what they have suggested to us or recommended to us for opportunities for change. So I do think that there is a level of self-reflection that does have to happen when it comes to how we present the data. But I think the data speaks for itself. And so what we are trying to do is really elevate the lived experiences of the Black community, Black mothers and birthing people, and Black babies, so that that part of the story is also added on to the experience, because our hospital teams, we have them do an assessment, and every category we ask them to rate themselves initially. And every time they always rate themselves lowest in community and understanding the Black experience. They just don't have access to that. So we do have to have a level of personal experience that we bring to this. And I don't think it skews data, and I don't think it misinforms. I think it actually adds to it and supplements, so that the hospital teams can understand that these N numbers actually correlate to individual people and actually correlate to families, and there's a name attached to that N. So even if your Black birth rate is low, which, across the country and really here in our state, it's not the highest, there should be no reason that the disparity should exist in that extreme, but there is. And so we do have to attach names and faces and personal experiences to those ends, because otherwise they're just ends. And it makes it difficult for folks to connect to us as Black women if we are not looked at as, fellow humans, for lack of a better term.
Yes. And I will say, I did catch your presentation, love the concept of the sister circles, and just, creating that community for, for folks to share their experiences. But I'm just wondering, I know accountability is often looked at as sort of, like a issue here. And so just wondering what that looks like once folks are sharing about their experiences and feedback to what's happening in the hospitals. What does that accountability look like for the hospital systems that are involved in the collaborative?
I'll let you go first. Yeah, so I think I was going to say, I'll go first on this one. I think it's an ever-growing process for us for accountability, because it typically is the thing that is forgotten about when it comes to outcomes. So our last convening, we talked about survival. So a mom and a baby surviving childbirth should not be the gold standard for, well, we did fine, right? Because that survival might come with added trauma. That survival might come with all of the things that childbirth just brings up in general anyway, let alone be a Black woman trying to birth a baby in a hospital system that was not set up for her, that was not set up for her family, that does not listen to her, et cetera. So I think the accountability piece is something that's kind of an ongoing process for us because, you know, certain individuals in our cohorts are very much willing to step up and say, I messed up here. What can I do better here? How can I better, you know, support Black patients, et cetera? But again, we're not just talking about the individual patient and provider interaction. We're talking about the system and the institution. So it is also a reflection of how does your institution treat your Black staff? There needs to be accountability there as well, because that Black staff could also potentially be a patient, right? Could also, you know, when we come into a hospital, it's not the letters after our name or the degrees or the experience or the work experience that we have. It's what are we presenting as and how are they viewing me as a human? And so I think the accountability piece is twofold. It's always kind of, we're constantly needing to mold it, but I also think that the accountability piece goes much larger than the healthcare system, right? It's on a national level. Where is the accountability towards Black women and babies, right? And you can take that down. It can be macro, and it can be where's the federal paid leave for mothers, right? We don't have that. Well, in California, we have that, but how does that impact Black mothers who often have to go back to work at 2 weeks because she can't actually afford 50% of her pay? So if she had any sort of childbirth complications, which the data tells us she is more likely to, how is the system set up to be accountable to her and to her family, right? So I think that there is a lot of work to be done there. I think how we strive to do it in Cherished Futures is doing small tests of change during the coaching calls. So it's like, this is what your data says this month. How are we going to track that and change that for our next meeting? So there are those little wins that we're looking for, that we are looking for. If you stated you're here with your community engagement, how are we progressing forward by our next meeting or for the next quarter? What authentic partnerships have you created or developed? How are you putting money towards, you know, initiatives or Black-led CBOs that will help to support, you know, the patients that come through your doors? So there's lots of mechanisms for accountability, and we are still learning as we go. But you know, that's an area that we hope to obviously increase in very much so in the near future.
And I'll add that some smaller scale, I guess, micro level forms of accountability that our hospitals, our core hospitals have taken. Some have released press releases announcing their participation in Cherished Futures, which to us is a promise to the community or a promise to the public. Like, yeah, in 2020, we were all about equity, and we kept talking, we kept putting out those statements, and we created a whole new page. We're walking the walk. We're walking the walk. We were talking the talk, now we're walking the walk. We're participating in this initiative, et cetera, et cetera. Other forms of accountability, some hospitals have stronger relationships or collaborative relationships with their community advisors. So we have community advisors that are assigned to our cohort hospitals, and some really take advantage of that connection that they have to the community. And that is a level of accountability. To have that kind of hospital community partnership it's not historically the norm. So we're starting to see some hospitals engage with that, but we're now in about year 3 of Cherished Futures. And just like Asaya said, accountability is hard. Institutional accountability is kind of hard to define, and it's very hospital or site specific. So we try our best to see where hospitals are at, what can they do, and then see what can be done in terms of accountability, especially for the public facing accountability.
Great, thank you both for your time. Thank you both for your presentation and your participation in this year's AMCHP conference. And thanks to all of you who watched the presentation and who joined us for question and answer. We hope that you enjoy day 2 of the AMCHP conference and that you join us tomorrow for the final day. It's been such a lovely week to connect with you all. I hope you all have a great night or evening or afternoon, wherever you may be. But thank you. Have a great one.
Thank you all. Thanks for having us.
Thank you.